Hi, everyone. Thank you for joining us today. My name is Stephanie Doback, and I'll be the moderator for today's webinar titled Feeding Tube Management and Consideration in People with ALS. I'm excited to introduce our speakers, Emery Finley and Simone Pappalardo. Emery graduated from Washington State University Coordinated Program in Dietetics. Originally from Madison, Wisconsin, Emery has called the Northwest home for the past 11 years. Emery started working in home infusion with Providence Infusion and Pharmacy Services right after school over 6 years ago. She loves working in the home and community care space, being more hands-on with patients, developing relationships, and meeting them where they are. She recently joined the team at St. Luke's Interdisciplinary ALS Clinic in Spokane. When not working, you can find her playing outdoors, rock climbing, snowboarding, and mountain biking with her husband and dogs. Simone graduated from the University of Alabama and completed her dietetic internship with Utah State University. Simone is a California native, but has called Spokane, Washington home for about 11 years now. Like Emery, she is also a clinical dietitian at Providence Infusion and Pharmacy Services. For the past 4 years, she has worked with the adult population who receives home enteral nutrition support and is currently dabbling in pediatrics to expand her knowledge. Simone loves her job because it is a combination of clinical, outpatient, and home health all wrapped into one. In addition to her position in home infusion, Simone has been a part of the interdisciplinary team at the St. Luke's ALS Clinic in Spokane for 2 years. She has found it fulfilling to provide nutrition counseling and support to these patients and their families. We will have a Q&A session at the end of our presentation, like usual. You can submit questions via the chat feature at any time during the presentation. You can also raise your Zoom hand at the end, and we'll call on you if you want to unmute yourself and ask the question. I'm going to put the CPE certificate in the chat box. In order to claim CPE credit, we must have an evaluation. So at the end of our session, I'll place a link to the 4-question evaluation in the chat box, and we ask that you please complete it so that we can have feedback to continually improve our educational offerings. Lastly, we want to thank the ALS Association for providing the Quality of Care Program grant to support this presentation. And with that, I'll hand it over to Emery and Simone.
Well, thank you guys for joining today. So, like Stephanie said, this is on feeding tube management and consideration in PALS. Conflicts of interest, we do work with a home infusion and pharmacy service company. Our objectives for today are to understand tube placement and replacement protocol, recognize different types of feeding tubes, recognize different types of feeding tubes and their adapters, identify different types of feeding tube connections, such as infant versus legacy, discuss the importance of G-tube assessment during the nutrition assessment of PALS, and understand the common issues with feeding tubes and best practice for troubleshooting. So just a little backstory on our experience and what we do. So we provide in-person teaching for patients and how to use their feeding tube. Often this includes their family members, maybe a caregiver, and showing them how to administer their tube feeding. We do continued follow-up either by phone or home visits. We monitor their tolerance and compliance to their tube feeding regimen, adjust that as needed. If appropriate, we'll transition them to or from an oral diet. We monitor their growth and their weight trends, troubleshoot any pump or equipment errors, and then offer assistance for their feeding tube replacements.
Here's a picture depicting different kinds of tubes, and then we're going to go into those in a bit more depth. The ones we aren't going to go into are NG tubes or NJ tubes because we're not seeing these placed in the ALS population because they're not a good long-term feeding solution. So before we do that, we do have a short 5-minute video on a balloon G-tube placement, and this one is placed radiologically.
Using a Luer slip syringe, inflate the balloon with sterile or distilled water through the balloon port. Remove the syringe and verify balloon integrity by gently squeezing the balloon to check for leaks. Visually inspect the balloon to verify symmetry. Place the patient in the supine position. Identify the medial edge of the liver by CT scan or ultrasound. Insufflate the stomach with air using a nasogastric catheter until adequate distension is achieved. Using fluoroscopy, choose a location that allows as direct a vertical needle path as possible. Placing the safety pexy. Place a skin mark at the tube insertion site and define the gastropexy pattern by placing 3 skin marks equidistant from the tube insertion site and in a triangular configuration. Allow adequate distance, approximately 2 centimeters, between the insertion site and safety pexy placement, so as to prevent interference of the anchor set and balloon once inflated. Attach a Luer slip syringe containing 1 to 3 milliliters of sterile water or saline to the needle hub. Under fluoroscopic guidance, insert the preloaded safety pexy slotted needle with a single sharp thrust through one of the marked corners of the triangle until it is within the gastric lumen. The simultaneous return of air into the syringe and fluoroscopic visualization confirms correct intragastric position. After confirmation of correct position, release the suture strand and remove the syringe from the device. Bend the locking tab on the needle hub. Firmly push the inner hub into the outer hub until the locking mechanism clicks into place. This will dislodge the T-bar from the end of the needle and lock the inner stylet into position, blunting the needle. Withdraw the needle while continuing to gently pull the T-bar until it is flush against the gastric mucosa. Gently slide the suture lock down to the abdominal wall. A small hemostat may be clamped above the suture lock to temporarily hold it in place. Repeat the procedure until all 3 devices have been inserted in the corners of the triangle. Creating the stoma tract. With the stomach still insufflated and in apposition to the abdominal wall, identify the puncture site at the center of the gastropexy pattern. Insert the safety introducer needle into the gastric lumen. Advance the J guide wire, J end first, through the needle into the gastric lumen and confirm position. Remove the safety introducer needle, keeping the J guide wire in place, and activate the safety collar. Slide the introducer needle safety collar down to the needle shaft while removing the safety introducer needle to prevent inadvertent needle stick. Use the number 11 safety scalpel blade to create a small skin incision that extends alongside the guide wire, downward through the subcutaneous tissue and the fascia of the abdominal musculature. Apply water-soluble lubricant at incision site. Advance the serial dilator over the guide wire. Use a firm clockwise-counterclockwise twisting motion to initiate advancement of the dilator sheath into the gastric lumen. Stay perpendicular to the skin while dilating so as not to kink the J guide wire. Fluoroscopically verify placement of the dilator tip into the stomach. While holding the serial dilator stationary, grasp the next dilator sleeve and with a clockwise-counterclockwise twisting motion, advance the next dilator into the stoma tract. Slide the segment forward until a physical stop is felt. Advance the red color-coded sleeve through the stoma tract and into the stomach. Continue dilation until all dilator sleeves have been advanced. Twist the dilator hub to release the peel-away sheath from the dilator. Lubricate the exterior of the peel-away sheath with a water-soluble lubricant and advance the sheath through the tract and into the stomach. Remove the dilator and J-guide wire, leaving the peel-away sheath in the stomach. Advance the distal end of the tube over the guide wire and into the stomach. After the tube has been advanced through the peel-away sheath and is in position in the stomach, peel the sheath away from the tube. Remove the guide wire. Using a Luer slip syringe, inflate the balloon. Gently pull the tube up and away from the abdomen until the balloon contacts the inner stomach wall and a slight tension is felt. The balloon should now abut the stomach wall. Gently slide the secure lock external retention ring down the tube toward the abdomen until it rests 2 to 3 millimeters above the skin.
Okay.
So that video just did a good job kind of showing how it's placed, and that one is a balloon tube. So the picture on the left has a long balloon G tube and then a low profile or a button. And you'll see that picture we zoomed in on upper right hand corner, we have the port. And this is the way to tell if it's a balloon tube or a non-balloon tube. So you can see that white balloon port, it has the French size of the tube. This one is a 16 French. And then it has the recommended fill volume of the balloon. And this one is to fill between 3 and 5 milliliters. The tube on the bottom is a PEG pull-through tube, a percutaneous endoscopic gastrostomy tube. So it's a non-balloon. Instead of the balloon that holds it in place, you'll see kind of that like mushroom cap looking retention device there. And it's placed endoscopically and then kind of pulled through the abdomen. The non-balloon tubes typically last longer than balloons because we can replace the Y port on it. So you want to make sure you're replacing the Y port with the correct French size. So that 16 French that we zoomed in on before, you want to make sure you're replacing it with a 16 French Y port adapter. The reason you would replace it is because those caps and the grooves, the end fit grooves, are usually the first thing to fail on the tube, because with that multiple daily use of screwing on and unscrewing on the caps and syringes and feeding bags, it just tends to break. If it's a balloon tube, you'd have to replace the whole tube. You're not able to remove that Y port. This slide has a J tube and a GJ. We don't usually see these placed with the ALS population, but you'll notice that the J tube on the left has a long tail. So J tubes can be placed a couple of different ways. This one with the long tail actually goes in through the stomach, and then the tail goes across the stomach, through the pylorus, and into the jejunum. You'll also see J tubes that are placed directly, tunneled into the abdomen directly into the jejunum, and they wouldn't have that long tail. And they can be a balloon or a non-balloon. The tube on the right is a GJ tube. This one has a gastric and a jejunal port. So placed similar to that long J tube, it goes in through the stomach, but then there's an opening into the stomach, and then it continues into the jejunum. So a GJ tube would be placed in somebody that might need to do some gastric decompression. It's important to kind of read op notes, because we often see like J tubes that are mislabeled as G tubes, because we want to make sure if somebody has a J tube, they're using a pump to administer formula and not a syringe. So this picture depicts like if you'd be looking at somebody with that tube. On the left is a patient that has a long tube, and then on the right is a button or low profile. With like most of our adults, at least where we're seeing in our area, they're getting placed a long tube first. And then if it's a balloon, that's a balloon tube, that is a tube that we could change after the stoma tract matures to a low profile feeding tube, just so it's less bulky.
Okay. So just want to talk about different types of connections for these tubes. So what you probably see or are used to seeing with feeding tubes is this legacy style straight tip straight connection, also known as like a cath tip syringe connection. On the left, you see the cath tip syringe going into a PEG tube. On the right side, that is a feeding set for pump feeds, and that's just a straight cath tip going into the tube. And it's not as common now since infit is best practice, and we'll go a little bit more into the infit style. So this was developed to reduce risk of misconnection, patient injury. The infit is solely for enteral feeding. This was a global implementation. The US is a little bit behind compared to other countries, especially UK has been doing it for, I think, over like 15 years now. We've been doing it. We've made a full transition with, like our supplies with our patients to the infant style for about 2 years now. And the positive for this is no more feeding the bed. So as you can see, this is just a, more secure connection to where that white tip wouldn't disconnect or accidentally pop out like we have definitely seen in the past. With the screw connection, the biggest thing to pay attention to is to avoid over tightening with medication or formula, potential buildup in those ports, and then somebody over tightening it can get stuck and be very difficult. And if you're thinking of the ALS population, maybe poor dexterity, that would be very hard for them to try to get this disconnected. So we always suggest just screwing it on just tight enough to secure. We've had to deal with maybe helping with hemostats to grip it really tight to unscrew it if that does get stuck. So with adapters, we see a lot of patients come out of the hospital with all these extra adapters attached to their tube that may be helpful, but may be just a little bit cumbersome that they don't need. So, for instance, if somebody has an infant tube and maybe they're in a facility where they only have these cath tip syringes, then they might benefit from this adapter, which connects to their feeding tube, and then they can use the cath tip connection to flush and feed them. However, if they're able to just get these infant style syringes that connects directly to their tube, and then they can minimize the use of an adapter and have it be less bulky on their tube. This photo is the infant tube with the adapter, and there's a feeding set bag connected. As you can see, there's a white tip that is connected to that feeding set. Now, at least what we're seeing on our end is that the manufacturer is no longer putting those white tips on the bag. So usually the patient has that just purple end that connects directly to their tube. But if they are receiving supplies that has that white tip adapter on there, they can just take it off to connect. Of course, if somebody for some reason does get a tube placed that is legacy style tube, then they would want some of those white adapters to then attach to the set or even to that purple syringe, and then they could still use with their legacy style tube. But like I said, we're really seeing infit across the board with all of our patients. This is just a good reference guide for other type of syringes and connections that you may see if a patient maybe got their hands on a different type of style syringe and they're trying to figure out if it's compatible with their tube. This could be helpful. It's all the way. So the first syringe upper left is legacy cath tip, shake tip type of syringe. The second photo on the top is a Lorlock syringe, which is commonly used for IV connections, but it actually can be used for deflating or inflating the balloon port of a G tube. The third upper photo is a slip tip syringe, and that is typically what we're using to bring to replace somebody's tube for the balloon port. So as you can see between that Lurlock and the slip tip, inside the Lurlock, it is a slip tip and it just has an outer piece on it. Liquid medication bottles sometimes have an adapter piece on the bottle, which the slip tip connects to pull that liquid med out. And then the upper right one is actually a Neomed oral syringe, which is not compatible with G tubes. And just briefly to show you how the low profile tubes and their connection looks like. So this is a low profile Mickey button. You would attach an extension to it to do the feeds. So as you can see kind of in order, the top left photo, you attach it by lining up the black line on the extension with the black line on that button. You push the extension down and then you would turn it clockwise just until it stops. So it does say, you know, the arrow to lock it, you just turn it until it stops. There is a valve in that connection, so you don't want to over tighten it and break the valve because then the tube would leak and not connect well. So we have our patients clean those extensions between their feeds. They can just rinse it and air dry them. And then they're replacing that extension once a week. They come in a white port extension, which is good for continuous feeds. There's a second port so that, maybe pause the feed to use a second port to do water flush or medication. And then there is a single port extension, like you see the baby here has. The tube is a little stiffer, it's a little bit bigger in diameter. So this is good for a bolus style feeding. Could also be good for just doing their water flushes, medications. And as you can see, they all come with a little clamp on there, so you can clamp it when you're disconnecting and connecting the syringe or the feeding set to those.
When we see patients in the clinic and other patients, we're always going to incorporate a G-tube assessment. We want to get eyes on the tube side, and this is kind of like our normal checklist we would run through. So we take a look at it, see if there's some leakage. Is it normal? Is it abnormal? Review tube site care if we need. Adjust the bolster, that circular disc on the tube. Check the integrity of the tube. Check the balloon volume. If maybe that tube has been in place for a couple of months, and then we can make sure that the patient's taking care of it. Thank you. So this we took out of somebody's chart in the lines, drains, and airways, and it shows that they had a 14 French MIC G-tube placed on 12/20 of last year. So just a good thing to put in your note, because you know what kind of tube is it. If it's a balloon, that's something that we can replace on the home front. And then that date would kind of clue you in onto when would be a good time to replace it. When we start a new patient, or if you're concerned with how somebody is taking care of the tube, it'd be a good idea to review site care. So how we teach it is instructing the patient to clean it daily with warm soapy water using like a gentle or mild soap. There's no need to use alcohol or hydrogen peroxide. We are going to supply them with split gauze, which is really helpful when the tube is healing because there's probably more leakage and blood. If after the tube is healed well and there's not a lot of leakage, you don't have to use the split gauze. Some patients, it's their preference, but we just make sure to tell them you do want to have some airflow to that site. You don't want to have a really occlusive bandage. The worst thing you could do is have a split gauze that is saturated, that they're not changing regularly. We want it to be clean, dry, and intact. On the right side, you see these 3 T-fasteners that we saw in the video. So those are going to secure the stomach to the abdominal wall. And we have the bolster on one side and the balloon on the other, sandwiching that stomach and abdominal wall. So those T-fasteners usually fall off within 14 days. If they haven't fallen off, then that's something that we can just snip under. It's just a single stitch. Because they're on after 14 days, often they get a little bit red and irritated and tender. The picture in the middle it has a few different things going on. So this person has a separate G and J. Their G tube is the one that's on top, and it's a mini 1 button, and then the one below is a Mickey button. So we wanted to include this because it just does a good job showing that one site looks really red and irritated and the other one does not. And then the other thing I didn't mention was taking a bath or a shower with your tube. So we tell people to wait about 72 hours from when the tube was placed to get it wet. And then at that point, that's a fine time to take the bandage off, let warm soapy water drip all around that tube site in a shower, but you do have to avoid a bath where you would submerge that tube site. We want to wait about 6 weeks until that stoma tract is mature and healed. Oh, I should have done a trigger warning, but we have some little gross pictures here. We asked our coworkers to help us out with some tube site and skin stuff they'd come across. So this first one on the left is somebody that has really, really bad leakage. You can see the skin around the tube site is red, raw, kind of looks like it's burnt from that acidic gastric leakage. So this could be caused from improper stoma healing, a tube that's displaced, and we would definitely direct them to see their doctor. This picture in the middle is a yeast infection. If you were to be brave enough to get close and smell around the tube site, it would smell yeasty. So this is caused from like a damp, warm environment. So that could be that example of the split gauze that is wet, that somebody is just keeping there and not changing. The picture on the right side is cellulitis, a bacterial infection. And this could be caused from improper cleaning. We could also have some irritation and redness if those 3 T-site fasteners were on past the 14 days. So in all of these cases, we're going to defer them to the doctor, but we think it's really helpful to kind of figure out what's going on because we want to prevent this from happening again. More tube site complications. Granulation tissue is the most common one that we'll see, and it can be part of the normal healing process. The picture in the middle really illustrates it well. It's kind of like a red fleshy ring. It can bleed a lot because it's very vascular and it can be tender. So it's caused because the stoma is trying to heal itself and close, but it can't because the tube is there. So that tissue just kind of forms around it. So causes can be if a tube is moving around a lot. You can see that picture on the bottom. Somebody has taped it to their abdomen really well because we want to prevent moving a lot. That can kind of bring granulation tissue on. Another cause could be a Mickey button that's too long and it's just kind of moving up and down in that stoma tract. What we can do to deal with it, if it's not big, so I would say the picture on the top, the granulation tissue is kind of still small. We would probably start by recommending they use over-the-counter hydrocortisone cream and dab it a couple of times a day for the next 2 weeks. If it's gotten to the size of that middle picture, that would be a good time to refer them to their doctor for silver nitrate treatment. And sometimes it can take a couple of applications. This picture shows a pressure injury. That bolster is really, really tight, and you can see the indentations on their abdomen. So causes are that bolster is too tight. So what we'll do, and this is something that we can do and we don't have to refer them to their doctor. It can be a little tough to loosen up that bolster, especially if the tube was placed. So the bolster, we want it to be pretty snug at first placement. And so we wouldn't consider loosening up that bolster for at least a week from when the tube is placed. But if it's after a week and the patient's really complaining of that bolster being too tight and we can see kind of the start of the pressure injury, we would want to loosen it. So hemostats can, again, be pretty useful. We're going to grasp the tube under the bolster with the hemostats just to hold it as we lift up that bolster. And sometimes it's a little sticky. So you can use that split gauze as a prevention to kind of pad under there, but you might just have to loosen up the bolster. This next tube site complication, buried bumper syndrome, I would say one of the more serious ones. We don't see it a ton, but we definitely have seen it. I think we both had a patient in the last month that had buried bumper syndrome. So we chose this picture on top because it shows a couple of different things. So you can see the skin, like the balloon is kind of bulging from the inside. And then the other thing that I'm seeing is that retention bolster is below the 2 centimeter mark. So that's telling me it could be displaced out of the stomach because on most adults, that bolster is going to hit like a 4 centimeter and above. We're really seeing like 2 and less with children. So if you see this or you're concerned, I would say better safe than sorry. You want to tell your patient, do not use the tube at all, not even water flushes. And go to your doctor, verify placement. We have had a couple patients that they've used it and it's led to sepsis and an admit. The other thing that could be a sign or symptom is if the patient flushes it or uses a tube for formula, and then you see like formula or water leaking from around that stoma site. Risk factors for this would be somebody that has a tube placed and then they have rapid weight gain and that bolster hasn't been loosened. Some patient that has accidentally pulled their tube or gotten it snagged, or somebody that is placing multiple split gauze underneath that bolster. And you can see how that bolster is kind of migrating into the stomach and the abdominal wall on the bottom one. This picture, Simone took of one of her patients. So this is a PEG tube, that non-balloon G tube that somebody has had in for over a year. And that's why we try to get these replaced about every year. And sometimes we'll have pushback with doctors that say, well, if it's working fine, it's flushing fine, why do we need to replace it? This one you can see it's very discolored, it looks bumpy, they tend to get hard and they can crack. And we're really worried about like bacterial and fungal colonization within the tube. So if patients getting pushback, that's when we would kind of like personally reach out to the doctor, maybe upload a picture and say like, these are the reasons why it should get replaced, and see if they can replace it to a balloon tube. And then we can replace it on the home front.
Okay, so tube clogs. We definitely do a thorough review on how to prevent tube clogs for our patients. The first thing is always flushing with room temp water. A lot of the ALS patients are getting their tubes placed, maybe before they're needing to use it. So we're always encouraging them to flush it at least once a day. Sometimes I tell people do it twice a day, morning and night. And then, just 60 mils, 1 syringe of warm water just to keep that patent and clean. The most common cause for a clog is usually medications. So if meds are going through the tube, they need to be crushed very well, mixed with about 30 mils of warm water, so it becomes a slurry. And then we're telling them to always flush 30 to 60 mils of water before and after that medication pass. Of course, we're always making sure that they check with their pharmacy that whatever they're putting through their tube is okay to put through their tube, that it's okay to be crushed or opened and mixed with water. So lots of flushing with medication. If it does get clogged, we recommend that they massage the outer part of their tube if they can see where maybe it got stuck. Try to push in some warm water, very warm water, let it sit for up to 20 minutes, and then take a smaller syringe, like a 10 mil syringe, and they would just attach that to the port and push and pull with air, like a plunger. And we're really telling them to put some like elbow grease into it, like push hard, as long as it doesn't cause any sort of discomfort. And that usually helps loosen up the clog and kind of push it through their tube. Sometimes they have to repeat it several times. So I've kind of gone over these steps with the patient and told them, do that several times, call me back in 20, 30 minutes. If you're calling me sooner than that, it's because you didn't try enough times. So then usually that does the trick for unclogging a tube. And they're unable to get it unclogged. If they have a balloon style tube, it could be just replaced if, there's somebody that's trained that can do it for them. Or they'd have to go to the ER. They do have enzymes that help break down the clog to clean it out without having to replace the tube. If that doesn't work at the hospital, then they would likely just replace the tube. Okay, so I have a couple quick videos, so bear with me when I get these up. But for tube replacements, for that non-balloon tube, like Emery mentioned, by a year, we're really pushing to advocate for the patient to get that replaced. And oftentimes we're seeing them when they get that tube pulled out, they're placing a balloon tube so that then we can be routinely placing it or having their caregiver routinely place it every 3 to 6 months. And then, of course, if they just have that tube in place and the whole thing doesn't need to be changed, changing out that Y port as needed to keep it working well. And for the balloon tube, every 3 to 6 months, that can be replaced at the home, in the clinic with a trained professional. So I will show you these videos. So none of these videos have sound, but you'll see this provider is just going to firmly pull the non-balloon tube just straight out of this patient's abdomen. So obviously doing this in a clinic where they can numb up that area, maybe with lidocaine, because it's not going to be the most pleasant thing to have done. And then I'm going to pull the other one up here. And then once that tube is out, they would hopefully place a G tube, a balloon G tube. Okay, so we'll get this one up. Whoops. I just want to make sure you guys can see the screen. Okay. Whoops. So for this, whoops, balloon G tube, I would definitely recommend using gloves, unlike the person in the video. She is deflating the balloon with that slip tip syringe, pulling out the fluid that is in there. Looks like she has everything ready with the other tube with lubricating jelly already on it to help guide it in. There is that blue piece in the tube is called a stylet, and that helps stiffen up the tube so that it goes in, easily, and then inflating the balloon with the appropriate volume based on the balloon type. They usually will say in the packaging how many mils to put in. Once that balloon is inflated, you can remove the stiffener stylet and attach an extension, twist it just until it stops. And then she's actually checking for stomach contents. We actually don't typically do this. That end is in the stomach. Someone's had the tube, their tract is healed well, likely is not going in anywhere else besides in the stomach. And we would actually just flush water to make sure it's flowing well. So I always just do like a 30 or 60 ml flush of water and then close the tab. You can definitely rotate it 360, and that is it. To briefly touch on was just tube replacement from the long tube to a button. I really wouldn't recommend doing this unless you have changed tubes before, and maybe even see somebody do this change over to a button, because it is just like slightly tricky. But there is a stoma measuring device you see on the left-hand side. It looks a lot like a long G tube. It's actually a 12 French size tube, and it comes with a slip tip syringe. And if I'm going to go change a patient's tube from a long tube to a button, especially for our ALS patients, for quality of life, not having a long dangling tube, I see a lot of my ALS patients want a button, especially if they get that tube early and aren't really using it. So we can't do it until after 6 weeks when that stoma tract has healed well. I will look at their current tube and see the centimeter mark of where that disc is sitting on the tube to get an idea of the length of their stoma. So for example, if that disc is sitting at, the 4 centimeter mark, then I know the button is going to be, maybe at 16 French 4 centimeter button. But I will actually bring a couple different sizes just in case. So I'll bring a stoma measuring device, maybe a 3.5 centimeter, a 4.0, and a 4.5 centimeter button. So I have some options just in case. But we would deflate the balloon, remove the long tube, place that stoma measuring tube in, and then that disc that's on the tube moves up and down very easily on the tubing. So you can just push it down till it lands on the appropriate centimeter mark so it's flush against the skin. And then I would note that marking that it's at, then I can deflate that balloon, remove it, and then place that button and inflate the balloon, and they're good to go. But like I said, it's a little tricky, and sometimes, you may not have the right size with you, and but it's great to be able to change people over to a button just for their quality of life. And that is it for our presentation. And any questions you guys might have.
Thank you guys so much.